On-the-scene video coverage of ESC 2012 is supported by Pradaxa.
Hello, I'm Tony DeMaria, the editor of JACC, and I'm here in Munich at the European Society of Cardiology meeting, and I'm here with Chris Cannon, the editor of CardioSource, and talking about the late-breaking trials here today. And perhaps the most important trial was the intra-aortic balloon counterpulsation trial, the so-called SHOCK II trial. And interestingly enough, even though intra-aortic balloon counterpulsation for shock has a class 1 indication, 1C or 1B, depending upon which guidelines you're looking at, there hasn't been much in the way of data to support this application in randomized trials. So this was the first randomized trial, patients with cardiogenic shock, randomized either to balloon pump or not balloon pump, 30-day mortality. And in fact, it was a negative trial. There was no significant difference in the patients who received pumps as opposed to those who didn't, Chris.
Well, it's a surprising finding. I think these are obviously the sickest coronary patients that exist, and often we have to put in balloon pumps to support them. This was trying to look at sort of prophylactic use on the way towards revascularization. And I think this points to the fact that the revascularization ends up being the key driver that's been seen in multiple studies of good outcome. And tiding along with a prophylactic balloon pump didn't seem to help. There'll still be some people that will need it because their blood pressure is, terrible and they just can't do the procedures, but to have that more of a routine, I think that'll back off a little bit.
Yeah, absolutely. The same thing occurred to me. In my practice, I see patients in cardiogenic shock that are really failing, and in those patients, oftentimes the balloon pump stabilizes them. Interestingly enough, no adverse effects in this study, so you didn't lose anything by putting it in. And you always wonder about enrollment criteria. Mortality rate of 41% in cardiogenic shock, maybe they weren't the kind of patients you and I see that are really doing very poorly.
Yeah, well, certainly we know that getting into a trial, it's a more select group, but still 40% is bad, but interestingly not improved by that routine use of balloon pumping.
Right. Now, the largest trial comparing two drug-eluting stents was the PROTECT study, and that was presented today comparing the zodorolimus-eluting stent, the Endeavor stent, against the Cypher stent, sirolimus. And in fact, in this very careful comparison with an endpoint of late stent thrombosis, what was found is that there really was no difference between the two stents. However, in subsequent analysis, a landmark analysis indicated that after 1 year, there was less late stent thrombosis with zodorolimus as one might have expected. But interestingly enough, there was a bit more target vessel revascularization, target lesion revascularization. So again, essentially a negative study, although some positives for zodorolimus.
It's a difficult thing clinically to use since the Cypher or sirolimus stent is no longer available. I think it brings to the forefront our constant worry about stent thrombosis. Maybe that's a little bit less in that very late time period. Nonetheless, I think we do everything we can of trying to select patients well. Ongoing debate of do we give clopidogrel or not, beyond that 1 year time period. But of the second generation drug-eluting stents, not that much of a win over the first generation here.
Yeah, interestingly, I agree with you. The incidence of late stent thrombosis was so low that to power these trials for that endpoint is going to be very challenging indeed. Now, the Gary trial was the German aortic valve stenosis registry. So It was a registry report. However, in Germany, in Europe in general, they've used many more of the TAVR procedures than we have in the United States. So they had a large registry comparing patients who received TAVR using both SAPIEN and the core valve, and compared them to patients who underwent conventional surgical aortic valve replacement. And of course, it wasn't a prospective trial, it was a registry. And I guess the most important conclusions you could draw from it, Chris, is that we're getting better with the TAVR procedure, particularly transfemoral, because the complication rate was less and the success rate was higher in this very large German registry. Again, mostly elderly, high-risk patients, but not exclusively.
You know, it's a growing problem, I think, of the number of patients get referred to our center for this, and they're all train wrecks. And it's nice to see that, you know, things are improving in terms of outcomes. I think Peter Block has written an editorial about there is definitely a learning curve, that people need to know the tricks, and these are very sick patients. And so obviously good news out of the beneficial learning curve here.
Yeah, I think encouraging that in these sick patients that have few alternatives, that this is really good procedure. Now, the indication creep, I think, is something we'll have to keep our eye on, because there's still significant complications. But I think the take-home message is that the TAVR procedure is getting better and likely will continue to improve. We'll be back in a minute with more clinical trials.